Okay, thank you to Tony and John for inviting us, and for Susan and her team for coordinating everything. And let me just get familiar here. Oops. Okay, that makes it go forward. Where do you get the little light? Right there. Okay. Thank you. I'm going to hit on a couple of points that reemphasize things that John brought up. They're issues that are common. We discuss them weekly in Tumor Board, and so I want to just reemphasize those. On your questions, I sent this to Susan. On mine, I gave you the answer. It's number 2. I meant for her to not put that. This is the answer. Pretend you don't see that. All right, and John, where is the timing thing going to come from? So I'm ready for that. Yeah. Oh, there she is. Got 0. Okay, got plenty of time. All right, let's get going. So what I want to do is tell you a little bit about brain cancer. We're going to expand on glioma and kind of where we are with treatment. We'll just tell you a little bit about what's going on with biological research related to cellular behaviors. Susan's given you a nice presentation. It's critical that we have laboratory scientists like her in our state and our region doing this kind of research. This competes with anybody in the country. And this is how we're going to get better with treating this disease. Just as John indicated, through the history of radiation therapy, we can generate better outcomes for patients, but we have to better understand the disease. Okay, brain cancer is unique to systemic solid cancers. I'm somewhat always torn by calling it a solid cancer. It seems to be almost more like a liquid cancer, to be honest with you. But it's in your brain, it's in the nervous system. And the 2 most important prognostic factors, meaning how patients will do, is their age and their functional status. So if we do something that impacts their functional status, either the neurosurgeon generates a hemiparesis or an aphasia, they have an adverse outcome related to radiation therapy. We don't manage their cerebral edema with corticosteroids correctly. We let them stay in sustained seizures. All this impacts folks functionally, and that functional status remains the second most powerful prognostic factor there is. And so it's essential we think of this disease in the context of the tissue that it resides in, which is our brain. Now, just some facts for you. There are about 23,000 new cases a year. Unfortunately, a lot of people die from this disease. There are no real changes in the incidence. So what that kind of tells us is if there's something going on in the environment or something that we're doing with our lifestyles, then you would expect this to go up or down. And we really don't see anything to that effect. Survival for brain cancer is really driven by how infiltrative it is in the brain. So if it's in a place where the neurosurgeons are successful in removing it, then these folks do really well. The more infiltrative this disease becomes, the poorer patients do. What we're going to talk about today is really over here in the glioma side, and this is where most of the malignant disease resides. The most common brain tumor is actually a meningioma, but over here is where most of the trouble resides. So we're going to focus really over on the glioma category. Interestingly, these are the Medicare mortality maps for primary brain cancer, and if we look at our region of the country, we can see that there's unfortunately fairly high mortality related to primary brain cancer relative to the other regions of the country. And that could suggest one of 2 things. One, that we're not very good at taking care of people with primary brain cancer, which I don't think is the case. Or 2, there's something in our region that increases our relative risk of this disease. And we are participating with a group at Moffitt Cancer Center, Vanderbilt, and Emory on a large epidemiological study trying to look into potential risk factors related to diet, occupation, lifestyle, or exposures. So glioma is the second leading cause of cancer death for young men. I think a lot of people don't actually realize that. It's one of the leading causes of cancer death for children. And unfortunately, 5-year survival for GBM is pretty low. Now, when I first made this slide, I had like a 2% there. It is up to 10%, which is an improvement. Unfortunately, when you look at something, the NCI has a metric called years of life lost due to cancer, and it's actually one of the highest. It's number 1 of 17 cancer sites in the UK, and number 4 of 22 in the United States. So this is a measure of the individual's burden of this disease. So it's quite high despite its low incidence. So where these tumors come from, there's nothing that we do that we know of that is linked to susceptibility to this disease. There are some studies which look at children who had ionizing radiation for leukemia that later in life developed astrocytomas. And again, this big epidemiology study we're a part of, as well as other groups at the University of California, San Francisco, and Mayo Clinic, have done studies which are called genome-wide association studies, looking for loci in our chromosomes that are associated with risk of this disease. And to date, 9 have been identified. Now, 80 have been identified for prostate cancer. So it's quite different, but this doesn't tell you what the genes are that put you at risk for this disease. It gives you a region of the chromosome that begins to direct the laboratory scientists. There's something in this area that is segregating with people that develop this disease. This is an easy study for people to participate in. All it requires is collection of saliva. So how do we treat this disease? We rely on 3 modalities: surgery, radiation therapy, chemotherapy. Surgery and radiation therapy have been the mainstay for many years. Chemotherapy, prior to the advent of temozolomide, was mainly nitrosourea based, really didn't offer a whole lot to patients, but we are seeing some improvements in that, which we'll cover. Gliomas, the 2 most common are the astrocytoma and the oligodendroglioma. Ependymoma also falls into this category. We're not going to touch on it today. But these are graded on the scale developed by the World Health Organization, the WHO scale. Astrocytoma we think of as grades 2, 3, and 4. Grade 1s are typically unique histological or pathological subtypes like pleomorphic xanthroastrocytoma, palicytic astrocytoma. Often can be dealt with by the neurosurgeons, may not even need adjuvant therapy. As you increase the number of these pathological features of bad behavior, you go up in grade and your survival goes down. Oligodendroglioma, a little bit different, kind of dividing these into low grade and then anaplastic. And we're going to talk about those a little bit because there is something new relative to anaplastic oligodendroglioma. So let's review this. These account for about 20% of the primary brain tumors. The anaplastic we call the grade 3. It has a distinct histological appearance. If you went to medical nursing school, you may remember the pathologist talking about the fried egg morphology. It's due to cytoplasmic clearing during fixation. And then also, if you're in the South, you know what chicken wire is. Whenever I give this talk somewhere else, they don't know what that is. But it's this capillary network that is reminiscent of what chicken wire is. Interesting, Greg Cairncross discovered that a large percentage of these had loss of 2 pieces of chromosomes. We call these 1p19q. And this can be assayed with a common test called FISH, fluorescent in situ hybridization. Now, Robert Jenkins at the Mayo figured out why these are lost, and then also others have begun to identify genes that are important actually in the development of the nervous system that also co-segregate mutations in these genes that are in patients with these losses. So we're beginning to kind of unravel things a little bit better molecularly. Well, why does all that matter? Several groups have observed that patients with anaplastic oligo did better than, say, people with glioblastoma. And if we were to look at those who have the combined allelic loss of 1p and 19q, we can see that they respond very well to treatment, and that's typically radiation therapy, or sometimes we consider chemotherapy. And if we look at survival curves related to this, we can see that people with loss do a whole lot better than people who have these chromosomes intact. Well, why does that matter? Back in the late 1990s, the U.S. through RTOG and then the Europeans through the EORTC started 2 studies of randomizing patients to get either radiation therapy or radiation therapy with chemotherapy. Now, it couldn't be concurrent because the drugs we had then were a combination of 3 drugs called PCV. So in the U.S., we gave it before radiation. The Europeans gave it after. Importantly, most patients couldn't tolerate all of the prescription course prescribed. Most people only got about half of it, primarily because PCV is quite toxic. But this study was originally reported in 2006 and then reported again last year at ASCO when all the final molecular analysis was done. And we see a nice separation of the survival curves for those who have a co-deletion. And if we look at median overall survival, it's 15 years for those who got chemo with their radiation and 7 for those who got radiation alone. That's important because it has some implications for patient care now. Radiation therapy by itself, we really wouldn't think of as adequate for those with 1p19q co-deletion. Now, the current data doesn't necessarily tell us should we give chemotherapy before radiation or radiation therapy and then chemotherapy. And also, since that time, this less toxic, more easy to administer drug, temozolomide, has come along, which we can give concurrent with radiation. And there is an ongoing RTOG study called CODEL trying to answer that particular question. So today, what am I doing for anaplastic oligos? John and I typically, for the majority of these patients, will treat them with radiation therapy and chemotherapy with temozolomide. All right. Now, the astrocytoma side of the house is divided into the anaplastic astrocytoma, the glioblastoma multiforme, very aggressive type tumors. These are a little more common in a slightly younger patient, these in a slightly older patient. Susan has given you a little insights into where these things are coming from. You know, we used to think these were dedifferentiation of mature astrocytes. A lot of impressive research identifying these pluripotential cells and their role in the propagation of this disease. You can get a glioblastoma one of 2 ways. The majority of folks show up with a primary GBM, so de novo. A smaller population transition from a low grade to an intermediate to a high grade. If we look at this series, we can see this is over here about 5% in a younger patient population. This over here is the majority in an older patient. And these do have specific molecular events that help determine this, particularly in the primaries, which are the most common. We have amplification of the epidermal growth factor receptor, and we have loss of PTEN, a tumor suppressor gene. Now, the current treatment is generated, was approved based on this study by Stoop back in 2005, where patients were randomized to get radiation therapy or radiation therapy and chemotherapy with the drug temozolomide. When I'm talking with a newly diagnosed patient, the information I share with them is when we look at overall survival and who's around 2 years later, it's about 10% if you were in the radiation therapy alone arm initially, and it's about 27% if you got chemotherapy with your radiation. So obviously you do better, but unfortunately the majority of patients will pass away by 2 years. Now, it is important to know that 70% of the people in the RT arm got Temodar, but they just got it at recurrence. So they just didn't take it concurrent with their radiation. And so that really begins to implicate that the benefit is by giving it concurrent with the radiation. There's a synergy. Now, concurrent with that paper was this other where they looked at this gene, MGMT, this stands for methylguanine methyltransferase. Temozolomide works by methylating the O6 position of guanine. And this little schematic shows that if the repair enzyme, this is a DNA repair enzyme, so if it's not there, then the cell dies if you give it temozolomide. If it's there, then the cell is resistant. So for people who have a methylated MGMT promoter, then this gene is not there. And this is the test. So when you order, sometimes it generates a little confusion on what the answer to this is when it comes back even from LabCorp, it will say MGMT methylated or unmethylated. And if it's methylated, that means it's absent. That's better. They're more likely to respond to the chemotherapy. And if we look at those survival curves, we can see for the methylated promoter, meaning that repair enzyme's absent, they're clearly doing better than those in whom it's present. Now, are we routinely checking this? No, we're not, unless the patient is in a clinical trial that stratifies people based on MGMT status. But I think we can be assured that over the next few years, we are going to be increasingly forced to address this issue, because this accounts for about 70% of the people fall into the unmethylated, and temozolomide is very expensive, and it may not be necessary that we're exposing them to this drug. Ongoing clinical trials are beginning to eliminate temozolomide for those who are unmethylated. And also, another question commonly asked of me is how long to give temozolomide in the maintenance phase. My notes will say up to 12 months. Oh my God, 10 minutes. But we got a break, so I may take it just a sliver of it. But it will say up to 12 months, but the approval is for 6. And the reality is the ECOG is actually going to initiate a trial where they eliminate maintenance temozolomide. So that question is still kind of out there and unanswered. John showed you some examples of pseudo-progression, and I really want to alert you to this. So don't get too alarmed with these initial MRIs right after radiation therapy in the era of radiation therapy and temozolomide. It's not uncommon to see increasing enhancement, increasing edema that will abate on itself with just some small doses of steroids. Really begin to educate yourself to the response criteria that we want to use are called RANO, and it relies on 3 factors. 1 is the MRI, both T1 and FLAIR. 2 is how a patient is doing, so clinically. And then 3 is dose of steroids. Is this going up or down? And even if the radiology report comes back saying increasing enhancement, increasing edema, worrisome for progression, and the patient's going to get that. They get all these documents. And then I think you just set the stage. I do not believe this is disease progression. I believe this is a response to therapy. Hold the course. Now, the behavior of this disease really relies on a number of cellular things that unfortunately are bad when they occur in the brain. Proliferation in the enclosed cranium, a lot of resistance and ability to survive in a hostile environment, like systemic cancer that metastasizes, this invades, and then angiogenesis forms these new blood vessels that not only feed the tumor but lead to a lot of edema in the brain, which compromises neurological function. There we go. John indicated that the TCGA, the Cancer Genome Atlas, sequenced over 500 glioblastoma, dividing them into these subtypes called proneural, neural, classical, mesenchymal. Interesting, if we look at the survival of these groups, they're not really all that different, okay? So we've got a little bit of a genotype, meaning a molecular fingerprint, that doesn't really correlate with outcome. And that contrasts somewhat to, say, breast cancer, where the same TCGA data set for breast cancer demonstrates a number of different subtypes that clearly have different prognostic implications. We are beginning to identify factors that are involved in these signaling cascades. As Susan has elucidated, drugs are developed that are impacting those. One is bevacizumab. It's approved for recurrent disease patients right now. We all are familiar with this kind of prior to administration of drug and enhancing mass, a lot of edema. Give the bev, enhancing mass goes away, edema better. Just be alert to those situations where the flare actually begins to get worse. So again here, enhancement goes away, but the flare is worsening in the opposite hemisphere. So be alert to the need to look at the T2 weighted sequences in these patients. John showed you these survival curves, 2 trials, RTOG and Roche-sponsored, newly diagnosed, randomized, double-blinded, over 1,500 patients. Both studies failed by their primary endpoint, which was overall survival. The RTOG failed on progression-free survival also. The Adaglio had a statistically significant progression-free survival. Kind of tells us that you get a benefit from Bev, but you're only going to get it one time. You can either get it in the beginning or you can get it when you recur. And so for people who undergo a complete resection, don't have a lot of edema mass effect, I would not give them Bev early. I would wait, okay? Now, Bev has some problems. You're at increased risk of venous thrombosis, and we won't really worry about that. So increased risk of a DVT, potentially a PTE, but you're also at increased risk of arterial thrombosis. This is what's more of a problem. In the brain, it's typically cerebral vascular disease or infarcts. So be alert to any patient that has an acute neurological change. I would get diffusion sequences with your MRI. You treat it just like you would if they had a stroke. You stop the Bev. If they're not on antiplatelet therapy, you put them on antiplatelet therapy. So there's a modest increase in venous thrombosis, but a marked in arterial thrombosis. If they have a venous thrombosis, they don't have a hemorrhage, it's okay to anticoagulate them. But if they have an arterial thrombosis, we really have to discontinue the VEGF therapy. So to kind of sum up here on my key points, I want to go back one. How do I do that? Take me back one. So molecular markers for anaplastic oligo, particularly related to 1p19q, you can ask pathology to do that. They can send it off. But that should drive your decision making on treatment. The ones with 1p19q intact, I would treat those like an anaplastic astrocytoma. Molecular markers for GBM, this is mainly NGMT status. I think we're going to increasingly see a role for this in making a determination about should we give temozolomide or not. Alert to pseudo-progression and the RANO criteria for determining treatment response. If patients are on Bev, be alert for pseudo-response, particularly if somebody's declining neurologically but their exam looks good. And then be aware of thrombotic events in patients with Bev. So those metastatic primary brain tumors are a significant health problem, really driven by their neurological disability. We rely on the standard therapies of surgery, radiation, as John's gone over a little bit about chemotherapy. Susan has kind of given you some idea of what we're doing to try to better understand these molecular events. This will lead to advances in treatment for this disease, just as we have seen in systemic solid cancers. So that's it. Thank you.